Hello and welcome to the Healthcare Today podcast. Recorded live at Health Europe in Amsterdam, our guest today is Niraj Dalmia, the head of AI for healthcare at Deloitte. Niraj brings deep experience across multiple jurisdictions from the NHS to global health systems, and has been at the forefront of deploying AI not as a bolt-on, but as a core driver of value. Today we're talking about real end-to-end AI transformations that are fundamentally changing how healthcare is delivered, experienced, and paid for. We'll explore tangible examples, the shift in paradigm, and what it actually takes to make AI work at scale. To start things off, what does end-to-end AI reimagination actually look like in a hospital or a health system today?
I think if I had to define AI reimagination, I would define it by saying that it is about taking an end-to-end value chain or process or processes in, let's say, a healthcare provider or a payer, and taking that 50-step process or 55-step process, whatever you, and reimagining, transforming that to essentially what a 20-step process could look like or a 22-step process look like. So it is about the technology per se, but it's also about the process, the imagination of something that you've been doing for decades long. Let's say discharging a patient for 50 years the same way. How do we do it now, given the technologies that we had? So if you had to build that process ground up from now in the world of AI and what exists right now, what would that look like versus an incremental change? And along with that, what is the jobs to be done by humans change? So a reimagined AI value chain is about the technology for sure, but it's also about the process change and the people change and how that changes how the day-to-day interaction happens.
How do you define value in this context? Is it clinical outcomes, operational efficiency? Is it patient experience, or is it all of the above? And how would you say you'd measure it?
I think it's interesting. It depends on who you ask. If you ask a clinician, they'll say, well, mostly it's about the administrative burden that they have. Value to them means how do we make their life better? And it was an interesting conversation I had with one of the CEOs here, and he said, well, value to him means how do you bring joy back to the lives of clinicians and nurses and clerks? And that I think is a fair game. It is not just about quantified cost reduction or quantified, patient outcome improvement. It's about bringing joy back into healthcare, and that could be value as well. Where some people, and especially on the finance side of things, might say, well, we have a lot of fiscal deficits in healthcare, and value to me is the reduction in cost, but also how do we get more bang for the buck for the same dollar or the same euro spent? In some cases, it's patient experience. Patients are expecting a lot more than what they used to back in the day, especially where consumer expectations are and how we're served digitally. And healthcare is lagging behind, as we all know. So for them, it's about patient experience. So it really depends on who you ask. But I think that the true question is, where do you start? In AI, it is about defining value, and then you go backwards from there.
Can you walk us through an example of end-to-end AA transformation from intake to diagnosis to treatment or follow-up?
Let's take an example. So, what happens right now when you discharge a patient? You do it in a way where on the day of discharge, you get an intimation saying, well, this patient's going to be discharged. So, you prepare all the notes, you send off these notices to the lab, to the pharmacy, to the billing department, you create a discharge summary, you start preparing the patient, you look at what's happening at home to make sure that the home care is ready to take them or wherever you're going to be sending them, and you put all of that manual work in discharging one patient. And often that takes more than a couple of days, or if it's done on a Friday, then the patient's waiting all weekend and ready to be discharged when that happens on a Monday. So that's sort of the current state of a very heavy manual end-to-end discharge process that has been legacy for as long as we know it. And when you think about a human plus AI transformation of that, think about if we had AI monitor every patient that's on the bed and look at their vitals, look at all the data that's already available and say, well, this patient's going to be ready for discharge in 2 days, and start all that activity from now on. So, automated patient discharge summary creation, obviously with human in the loop, looking at that discharge summary and validating it, but get all that documentation out of the way, sending off the notices to the pharmacy, to the labs, autonomously, getting the lab to do their lab work, getting the pharmacy to sign off the drugs, sending out the notification to home care. There's a lot that could be automated that are just administrative work with AI working with humans. Again, not truly end-to-end autonomous, at least yet, I'd say. I think we're going to get there. But at this point, there's a lot of low-hanging fruit in the end-to-end transformation. Now, to your point, if you take that upstream towards intake and scheduling and registration and booking, is the end-to-end administrative flow is it's full of opportunities when it comes to automation. And to some extent, we've done robotic automation, process automation quite a lot, which is rule-based. But that's so much only that you can get to when it's rule-based. It's got to be a lot more cognitive. And now with the advent of agentic AI, where these agents work autonomously with various ability to be probabilistic, not deterministic, the opportunities of autonomous agents in these workflows are just so tremendous.
On the operational side, where have you found that AI has driven unexpected value, for example, in bed management, discharge planning, or resource optimization?
To me, I think the primary areas to look at are areas where we're not even being able to fulfill with just humans. So, as an example, there are hospitals out there that have to only do post discharge check in with patients, whoever they can check in with. So, 20 to 30% of patients who get released from hospitals and go back home, who have a heart issue, only get a check in call. The remaining don't even get a check-in call because nurses are not available. And one would argue that nurses should be spending time bedside with patients, not making phone calls. So we're seeing a lot of these low-hanging, unexpected value creation opportunities where one might not think, okay, well, do we need AI here or not? But the barrier to entry is just so low because humans themselves are not able to fulfill those activities. So it's just a no-brainer to put AI in those tasks to be able to reach 100% of patients who are discharged and go back home, which from a value perspective, it's about patient experience and improving the outcomes. And then operationally, they don't come back to the ER.
You've worked across different health systems. What's one example, if you can give just one example, from other countries that the UK private and public healthcare systems could both learn from?
I think some things that we've done back in my country in Canada has been quite tremendous as it relates to creating better access to care through concept of a care companion that allows you to enter into the health system in a way that doesn't get you lost. So for example, can you have a care companion that you can have a conversation with and be able to guide you to the right care setting in a way that you don't have to stay on a waiting queue for an hour waiting for someone to be able to answer your questions. You could train AI agents to direct you to the right care with the lowest wait time, closest to you, the appropriate care. It doesn't have to always be the GP or the ER. There's several other care settings that are available out there. So in the world where we have capacity sometimes in the health system. It's just not being accessed correctly. And can you provide these 24/7 available agents that allow you to navigate care in a way that's plain conversational English language and you can access them anytime? And it's still based on clinical protocols and there still rests on certain validated clinical guidelines. So you're not making up anything here, but I think that's something that one should just implement regardless of the jurisdiction.
You've previously talked about changing the paradigm. To your mind, does that mean moving from reactive to predictive and even preventative care at population level? And if so, how close are we?
Yeah, I mean, changing the paradigm, one of them is about shifting left towards preventative and wellness. Again, like the technologies exist, we can predict with a high amount of accuracy if you or I are susceptible to heart disease right now, or sepsis, or stroke, or diabetes. We can predict that. So why are we not intervening and doing something about it? Well, our health system A is not funded like that. B, we need to bring an ecosystem of organizations together to provide the right nudges such that we can behaviorally get these people to change their actions. For example, smoking cessation or eating healthy or exercising more. We have all that data from wearables coming to us, and it is about liberating that data in a way that's safe and secure so that we can provide that personalized guidance and nudges to people. B, funding the health system in a way that incentivizes the organizations to prevent as opposed to cure. And then C, it's about incentivizing people to be able to act like that. Ultimately, the outcomes are lower cost to the health system and better outcomes. So that's one big paradigm shift among several that we can cite.
Let's look at it from the clinician point of view. What happens to them in this new paradigm? Are we augmenting, automating, or truly redefining roles?
There's a lot of schools of thought there. I don't think everyone understands the magnitude of what's happening with AI right now and what it can do and will do, rather being provocative, regardless of our choice. With the availability of AI that is so powerful and it's just going to get more available and less expensive as we get better at commoditizing it. I think from a clinician point of view, there will be certain tasks that perhaps can be a lot more automated. And radiology is an often cited one where AI just happens to be just so strong at it, looking at medical images and being trained on vast amount of data out there. So will we not need radiologists? No, of course we need radiologists, but will we need a radiologist to see every image? Probably not. A radiologist would see the most complex cases and probably have a supervisory capability. And we're already seeing some of that happen, but we're going to see that just happen a lot more. And there'll be higher acuity patients being seen by clinicians and the lower acuity patients being monitored and being seen by AI. You can translate that to pathology, you can translate that to dermatology. And so there is a real case that the clinician's job is going to be very different. And if you translate that to, let's say, not too far from now, maybe 10 years from now, we're going to see AI in surgery a lot more. And you could get a surgery in a remote distance, which we're seeing some flavors of that right now, and be all being conducted by AI with human supervision. And just imagine the power of that. So we're going to see that happen. It's just about how we think about changing up the model of care, the funding, the care pathway. Those are the hot bits. I think the technology is not going to be the hot bit.
Now, as you said, the technology is definitely here, but what's the biggest barrier that you see today from health systems stopping from moving from pilots to full end-to-end deployment?
Yeah, it goes back to my point around we get stuck in pilots because we think of this as a technology project. It is very much the right technology for the right intervention or the right use case, but this is more of a adoption, a change, a process change, a jobs to be done change problem. And if you don't figure that out from day one, then you're going to get a very successful technical go live of an AI model that no one will adopt. And we've seen thousands of that examples. So before you throw a shiny object over the fence and say, here you go, let's buy this chatbot or buy this really good looking AI tool, think about how that's going to be embedded in the day to day. And what does it mean for the people? What's in it for them? Why are they going to adopt it? How are you going to incentivize them? How is it going to bring joy to their lives? Those are things to be thought about in any technology adoption, and more so in AI because it's just so embedded in what we do. But to me, that's the biggest barrier right now, which is to think more holistically as we go ahead and implement these AI models.
Looking ahead 2 to 3 years, crystal ball time, what's one AI-driven change in healthcare that will feel completely normal, but today feels like science fiction?
Well, I think all of us will have an AI agent or whatever you want to call it, care companion or a humanoid robot or whatever it is, but something that's going to follow us across our care journey from being healthy to being sick to back to being healthy. We'll have our own care companions that will be personalized for us with the data that is provided by us, by the health system, by our shopping habits, by our exercise habits, and we all will be followed through the journey and not felt like we've dropped off somewhere and someone needs to pick us up. I think that's going to be a big step towards, again, shifting left and towards prevention, wellness, and self care, as well as ensuring that the health system is built for us versus us trying to comply with the health system.
Obviously, there's a bit of a gold rush to get to that point first. Interoperability is the key word here. How do we make that happen?
The formal answer is there's regulation that's coming into play and the bills being passed in the Senate and all various jurisdictions acting on trying to unlock that data with limited or no vendor lock-in and standards are being put out there. But my informal answer would be, I think we're just going to break it. We're just going to do it. And then regulation will follow and policy will follow and things will happen. And this might come from outside the sector, the private companies of the world that will just liberate that data for patients and they'll just start using it. And much like how patients are just using ChatGPT right now to ask questions about something that's happening to them right now, and they go to the physician and say, like, this is what ChatGPT is giving me. Well, that happened outside the system. So the health system is now trying to build it in their world from something that happened outside. So I think interoperability is going to follow the same route, which is it's just going to happen from outside the system, and someone will break the rules, and the health system will then just have to do it themselves.
And all of that without saying the word disruption once. Finally, if you could leave our listeners with a message about AI and value in healthcare, what would it be?
I would leave it with courage. I think we all need to think about healthcare as some sector that's not the sector that we can't be risk taking. We can take risks. We can be more courageous in taking a leap of faith on certain things that might not be fully proven. We do that in other sectors. Of course, we do it in certain industries like the space industry a lot more. And one has to do it in a bit of a controlled sandbox environment. But you can't be completely risk averse. You can't take zero risks. So I'll leave it to value creation only happens when you think through holistically, but then you also take some risks and you make it happen with some calculated assumptions. But without risks, you are going to be in this world of 5, 10, 20 years behind.
Niraj Dalmia, thank you so much for your time.
Thank you.